Now we're going to start talking about acetaminophen, nonsteroidal anti-inflammatories, and aspirin. Acetaminophen is a metabolite of phenacetin. This was introduced in 1887, but used extensively for many years, then taken off the market because it led to nephropathy. Acetaminophen has been used since 1893, but became very popular since 1949. Its effectiveness of the phenacetin has been experienced without the adverse reactions. However, acetaminophen overdosage may still cause nephropathy. The problem most frequently noted with acetaminophen involves difficulty in determining the proper dosage in children. The FDA continues to issue safety alerts on various preparations to state that the dosing is confusing. All cough and cold medications that contain acetaminophen and are marketed for children younger than 2 years have been withdrawn from the market. Current guidelines recommend avoiding the use of these products orally in children younger than 2 years of age because of the risk of toxicity associated with improper dosing. In addition, a new formulation of IV acetaminophen has become available and is used often within a hospital setting. The FDA has asked manufacturers of combination products containing acetaminophen to limit the amount to no more than 325 milligrams in each tablet, and this is to reduce the risk of overdosage. And this has been phased in over a number of years. So what are the indications of acetaminophen? It's used antipyretic as well as analgesic. For analgesic use, it's for acute, mild to moderate pain and chronic pain in conditions such as osteoarthritis and occasionally in rheumatoid arthritis. It's again now available in IV use for both pediatrics and adults. However, acetaminophen has little or no anti-inflammatory effects. Its unlabeled use is to decrease fever and pain in children receiving the DPT vaccination. It's also an over-the-counter medication that is commonly used for fever and mild pain. It can be used in patients who have experienced gastric irritation with aspirin or nonsteroidal anti-inflammatories. It's similar to aspirin in terms of its effectiveness in decreasing fever and pain. It is the drug of choice for relief of minor pain in children, adults, and elderly. Acetaminophen is different from aspirin that it has a weak anti-inflammatory effect, little GI adverse effects, and no impact on platelet aggregation. It is well tolerated at recommended dosages. A maximum adult total daily dose of 300 milligrams for self-treating users and 4 grams per day for those under the care of a clinician. At higher doses, acetaminophen can cause hepatotoxicity. So what is its mechanism of action for antipyretic? Acetaminophen reduces fever through the direct action of the hypothalamic heat regulating center, thereby lowering the set point to normal. It does this by inhibiting the action of pyrogenic cytokines on heat-regulating centers. This action increases dissipation of body heat via vasodilatation and sweating. For its analgesic effect, it is a centrally acting analgesic. Its site and mechanism of analgesic action are not clear, but may result from the inhibition of prostaglandin synthetase in the CNS. Acetaminophen differs from aspirin in that it does not inhibit peripheral prostaglandin synthesis, and this may account for the weaker absence of anti-inflammatory and platelet inhibiting effects. For the person with osteoarthritis, acetaminophen is the medication of first choice for mild pain. Little evidence suggests that acetaminophen provides any benefit with peripheral inflammation as a causative factor for the pain. Cardinal points of treatment. Acetaminophen is an over-the-counter medication. Many patients self-administer this product for both pain relief and fever reduction. Acetaminophen use appears relatively straightforward in adults. Maximum adult total dose is 3 grams per day for self-treating users and 4 grams per day for those under the care of a healthcare provider. However, all individuals, particularly children, its use becomes more complicated and presents many opportunities for overdosage. Different dosages are used for different age and weight groups, and many formulations with different strengths are available. Acetaminophen is a frequent constituent of other over-the-counter combination products, and these formulations change frequently. Evidence from past studies show that acetaminophen is the drug of choice for reduction of fever. Treatment of minor fever is not generally indicated. Symptomatic relief of fever greater than 40 degrees Celsius is usually required, and a temperature greater than 41.5 degrees Celsius, considered hyperpyrexia, constitutes a medical emergency. The decision to treat fever is based on circumstances. All fevers do not have to be treated with an antipyretic. Fever may serve as a protective physiologic mechanism. Treating the fever may prolong the course of infection, obscure symptoms, or may make it difficult for the provider to assess the patient's response to the infection. Fever should be treated if it affects the patient in bad ways, or if the patient is in significant discomfort as a result of the fever. For example, elderly can have tachycardia from fever that may decompensate their CHF. Children may experience seizures if their temperature is high. The patient may experience fluid and electrolyte imbalances because of the perspiration. These are reasons that fever should be treated. For non-pharmacological treatment, this consists of heat removal measures such as cold water, old-fashioned alcohol sponge baths, or the use of ice bags. Untreated fever may cause fluid and electrolyte losses through perspiration. These fluids and electrolytes must be replaced. For pharmacological treatment, pharmacological treatment of fever may consist of aspirin, nonsteroidals, or acetaminophen. Acetaminophen generally is preferred in children to avoid Reye syndrome, which is associated with some other antipyretic agents. Some adults may find aspirin or ibuprofen more effective. Acetaminophen is given every 4 to 6 hours, depending on its strength. If the patient has an illness that causes fever, it's often advisable to give medication routinely rather than as needed to prevent uncomfortable swings in temperature. However, maximum dose per day must not be exceeded. The introduction of IV acetaminophen has been found in some studies in Europe to be associated with serious accidental dosage errors, especially in small children. This is caused by calculating the dosage of milligrams, but then administering milliliters. The solution is 10 milligrams per mil, so a 10-fold overdose occurs if they're given milliliters. It's used for acute and mild and moderate pain. It's useful for mild to moderate non-inflammatory acute pain, such as headache, muscle ache, and malaise that accompanies a minor viral infection. It is commonly used in children to relieve pain of teething. It's not effective in the treatment of acute inflammation. The effectiveness of pain is better if acetaminophen is given routinely and not on a PRN dosage. IV is given as an adjunct to opioids. For chronic pain, acetaminophen is very effective for chronic pain of malignant or non-malignant origin. It's useful for the pain of osteoarthritis in the elderly who often cannot tolerate nonsteroidals. It's often used in combination with other medications to enhance their effectiveness. It's frequently combined with codeine and similar opioids as an adjunct medication. When acetaminophen is given in combination products, such as acetaminophen with codeine, it's important for you to monitor the daily intake of the acetaminophen to avoid any overdosage. It's also used for DPT vaccination. A dose should be given immediately following the vaccination and every 46 hours for 48 to 72 hours. This decreases the incidence of fever and reduces injection site pain. So how do we monitor this medication? We need to monitor temperature and track reduction of fever, monitor the relief of pain and presence of adverse effects. Acetaminophen may be found in many of the over-the-counter products, such as cold and sinus medications. You need to ask specifically about acetaminophen when taking a medication history to avoid any potential overdosing. Evaluation of overdose with IV formulation or oral dosage requires a serum acetaminophen concentration drawn 4 hours after infusion is started or as soon as possible. If the serum acetaminophen concentration plots above the treatment line on the Rumac-Matthew nonogram, treatment with acetylcysteine or mucomist should be initiated. The incident should be reported to regional poison centers so that dosing errors can be recorded. For patient variables, geriatric patients often have subclinical hepatic insufficiency and are at risk for acetaminophen toxicity. All patients, particularly those who are older, who are taking hepatic toxic drugs, who are alcoholics or have cirrhosis, should use this product with great care. The use of acetaminophen with elderly patients should be used with caution, especially when given in combination with alcohol and in patients with a known impaired hepatic function. Use lower doses and increase dosage intervals. This agent is safer than other drugs for the treatment of chronic pain. It can be used effectively. Pediatric patients, acetaminophen is used commonly for pain and fever in children and generally is well tolerated. However, you do need to use caution to avoid overdosage. In contrast to aspirin, acetaminophen may be given to children with viral infections because it's not associated with Reye syndrome. Because of the risk of Reye syndrome, children should never receive aspirin. Acetaminophen in general should not be used more than 5 days in children. Most overdosages occur with conscientious parents who inadvertently overdose sick children. Failure to give acetaminophen in proper concentration and dosage may lead to serious acetaminophen toxicity. Infant drops 80 milligrams per 0.8 mils are 3 times more concentrated than the elixir 160 milligrams per 5 mils. Children at increased risk for acetaminophen toxicity include those with diabetes, viral infections, a family history of hepatic toxic reactions, obese children, and chronically malnourished children. For those women who are pregnant and lactating, acetaminophen does cross the placenta. It's used routinely in pregnancy. It's considered a category B and appears to be safe for short-term use. No evidence has been found in a relationship between acetaminophen ingestion and congenital malformations. Acetaminophen is excreted in breast milk. However, no adverse effects have been reported in nursing infants. For patient education, keep the medication away from children. Severe pain or high fever may indicate a serious illness. If fever or high fever persists, the patient should contact their healthcare provider. The patient needs to avoid large consumptions of alcohol while taking acetaminophen because of the increased risk of liver damage or nephropathy. Generic acetaminophen is as effective as and less expensive than the brand name products, and you need to discuss mild cyclic elevations in temperature versus a true fever that requires treatment in these patients. Now we'll move on to aspirin and nonsteroidal anti-inflammatory medications. These medications are frequently used in practice. In general, saxilate or aspirin, nonsteroidal anti-inflammatories include the propionic acids, the acetic acids, indole and indene acetic acids, heteroaryl acetic acids, alkanones, phenamates, oxycans, and COX-2 inhibitors. Indication for use: for aspirin, short or long-term symptomatic treatment of mild to moderate pain, inflammation, fever, rheumatoid arthritis, osteoarthritis, and gout. It reduces the risk of recurrent TIAs or strokes in patients who have had TIAs caused by fibrin platelet emboli. It's used for the prevention and treatment of myocardial infarctions, acute ischemic strokes, and transient ischemic episodes. It reduces the risk of MIs with previous infarctions or unstable angina in men only. It may reduce the risk of Barrett's disease. Unlabeled uses include prevention of cataracts, toxemia in pregnancy, reduction of risk of colorectal adenoma, and the action of aspirin on blood clotting. For the nonsteroidal anti-inflammatories, most are used for osteoarthritis, rheumatoid arthritis, mild to moderate pain, including dental extractions, minor surgery, soft tissue, athletic injuries, and primary dysmenorrhea. Unlabeled uses include tendinitis, bursitis, and migraine headaches. Some recent research suggests that long-term nonsteroidals may decrease the incidence of Alzheimer's disease. However, these neurologic effects are negated if the individual has been taking aspirin for its cardioprotective effects. Some studies have shown that long-term use, more than 5 years, of some nonsteroidal anti-inflammatories, especially ibuprofen, but not celecoxib, lowers the relative risks of Alzheimer's disease. You need to remember that the different classes are chemically unrelated, but do share the same therapeutic actions and adverse effects. Non-steroidals are generally divided into 7 classes: the propionic acids, indoles and indenes, acetic acids, heteroaryl acetic acids, alkanones, phenamates, oxycans, and COX-2 inhibitors. Significant differences among the drugs have been noted. Although the COX-2 inhibitor may decrease the risk of GI effects, it's much more expensive than the other classes. A broad body of literature demonstrates that nonsteroidal anti-inflammatories are associated with an increased risk of serious and potential fatal thrombotic events, MI, and stroke, and adverse cardiovascular effects. These effects were once thought to occur only with the COX-2 nonsteroidals, but additional studies have demonstrated the risk with older nonsteroidal anti-inflammatories as well. Clinicians need to follow the findings of these continuing studies. Nonsteroidals, especially celecoxib, have been associated with increased risks of atrial fibrillation, and the American Heart Association discourages the use of nonsteroidals in patients with heart disease or high risk for heart disease. So what is the mechanism of action? Again, acetaminophen is different from aspirin, that in the nonsteroidals in that it does not have the significant anti-inflammatory effect that the nonsteroidals do. This is because the acetaminophen affects the COX in the brain but not in the peripheral tissue. Aspirins and nonsteroidal anti-inflammatories are closely related. They have this anti-inflammatory, analgesic, and antipyretic effects. All the drugs except celecoxib are available in generic form, and all these drugs can cause GI irritation and bleeding, which can be fatal in some patients. GI bleeding may occur with or without any prodromal symptoms. Aspirins and nonsteroidal anti-inflammatories reduce inflammation by inhibiting the production of prostaglandins, prostacyclin, and thromboxane, and in both the CNS and peripheral tissue. They do this by blocking COX enzyme. The major mechanism is involved in most of the effects achieved by aspirin and the nonsteroidals. Fact that the incidence of colon cancer have been found to be lower in patients who take aspirin on a regular basis. For pain, the mechanism for decreasing pain occurs through the anti-inflammatory process. Pain is relieved when prostaglandin production is blocked, resulting in reduced inflammation. Aspirin may cause some pain reduction centrally at subcortical sites. For the antipyretic effect, aspirin blocks the effect of interleukin-1 on the hypothalamus, which is responsible for temperature control. Peripherally, aspirin reduces fever by causing vasodilation of superficial blood vessels. This effect results in dissipation of heat. For platelet effects, platelet activation is stimulated by a thromboxane. This results in aggregation and clotting cascade ensues. The antiplatelet effect of nonsteroidals are caused by blocking of the COX-1 enzyme and production of thromboxane. Any drug that inhibits the COX-1 enzyme reduces the production of this. This effect is applied in the treatment of patients with cardiovascular disease. Aspirin causes irreversible inactivation of the COX, allowing decreased production of thromboxane for the life of the platelet, usually 8 to 10 days. Nonsteroidals, however, exhibit reversible inactivation of COX, which lasts only for the duration of the drug's activity, so continuous platelet aggregation is not found. This is why aspirin is used for patients with cardiovascular disease, whereas nonsteroidals are not effective. Ongoing research is examining the use of nonsteroidal anti-inflammatories in the treatment of patients with a variety of problems. This includes the use of nonsteroidals to reduce the risk of Alzheimer's. There has been a strong inverse link between breast cancer as well and nonsteroidal anti-inflammatory use. Nonsteroidal anti-inflammatories may protect against Parkinson's disease and may decrease the risk of colon cancer. For adverse effects, when prostaglandins are inhibited, more gastric acid is produced and the risk of mucosal damage is increased. Aspirin and nonsteroidals, by inhibiting prostaglandins, increase gastric acid production at the same time that they decrease the defense to that acid. This process serves as the basis for the adverse GI effects of these medications. Kidneys that are impaired also rely on prostaglandin to cause vasodilation. When prostaglandins are inhibited, vasodilation is lessened and blood flow to the kidneys is decreased. As with all nonsteroidal anti-inflammatories, long-term use of celecoxib can lead to renal papillary necrosis, renal insufficiency, acute renal failure, and other renal injuries. In patients whom renal prostaglandins have a compensatory role in the maintenance of renal perfusion, nonsteroidals may cause a dose-dependent reduction in prostaglandin formation and secondarily renal blood flow that may precipitate overt renal decomposition. Patients with impaired renal function, heart failure, or liver dysfunction, elderly patients, and those taking diuretics, ACE inhibitors, and angiotensin II receptor antagonists are at greater risk for this reaction. Discontinuation of nonsteroidal therapy usually is followed by recovery to the pretreatment state. In 2012, a study about individuals with an initial heart attack found that those who took nonsteroidals after their MI seemed to have a greater risk of death or a repeat attack in the next 5 years. Researchers found that 20% of nonsteroidal anti-inflammatory drug users died during the first year after the heart attack, compared to about 12% of the non-users. Treatment principles, evidence-based recommendations, patient education and exercise definitely improves the patient's well-being. Topical nonsteroidals, acupuncture, and tramadol are effective for pain relief, especially in osteoarthritis of the knee. Glucosamine and chondroitin do not relieve most of the osteoarthritis pain, but they may be effective in moderate to severe knee pain resulting from trauma or overuse. Increased gastroprotective agent adherence in celecoxib-treated patients is linked to reduced complications. Protein pump inhibitors, high-dose H2 receptor antagonists, and misoprostol have been found to reduce the incidence of non-selective non-steroidal anti-inflammatory induced upper GI tract ulcer complications. For the person with moderate to severe pain and or inflammation, a COX-2 selective nonsteroidal is usually the first choice unless the person is at significant risk for hypertension or renal disorder. In persons at high risk for hypertension and edema, you should use any nonsteroidal cautiously because of the risk of exacerbating hypertension or the edema. Non-selective nonsteroidal anti-inflammatories should be considered only if the person is not responsive to or is not able to take COX-2 selective nonsteroidals and or acetaminophen up to 4,000 milligrams per day, and only after a risk analysis has been done to determine the risk for significant nonsteroidal inflammatory induced GI complications. If such risk factors exist, then prophylactic agents such as a protein pump inhibitor or misoprostol should be given along with a non-selective nonsteroidal anti-inflammatory. The person at risk for cardiovascular events should be given a regular low-dose aspirin, whether the patient is treated with a non-selective or COX-2 selective nonsteroidal. Tramadol may be used alone or in combination with acetaminophen or nonsteroidals for therapy at any time during treatment of a person with osteoarthritis when nonsteroidals alone produce inadequate pain relief. So what are the cardinal points of treatment? You should begin with non-pharmacological treatment. When you need to move on to pharmacological treatment, the first line is acetaminophen, second line non-steroidal anti-inflammatories. The underlying goals of treatment are to limit the inflammatory process, protect the joints, and relieve pain. Non-pharmacological methods are important in all uses of nonsteroidals. If the patient has moderate pain, consider starting nonsteroidals at the same time that the non-pharmacological treatment is initiated. All nonsteroidals differ from one another in terms of the number of drug properties. Evaluation of these properties in relationship to the patient and the patient's condition will help in deciding which drug to choose. Wide variations have been noted in how patients respond to a particular medication, and as always, when many drugs are included in the same class, you as a provider should select a few and become familiar with them. Clinically, no clear guidelines and no evidence-based decision-making are able to assist you in selecting the most appropriate nonsteroidals for a particular patient, and again, this is more of matching the treatment with the actions of the medication. Aspirin can be effective and inexpensive. Up to 12 tablets a day are required, so compliance may be difficult. Salicylates are generally less expensive than the nonsteroidals. Because aspirin almost always causes GI distress or ulceration, their use is significantly limited. However, U.S. researchers have found that aspirin intake reduces a person's risk of developing Barrett's esophagus, which is the top risk factor for esophageal cancer. And this decreases by nearly 50%. The risk was lower in patients who took more than 325 milligrams of aspirin per day than those who took less. A comprehensive review of the patient's current drug regimen should be performed before having a patient take aspirin or nonsteroidals. Drug interactions with some products may increase the risk of GI effects. You need to consider the degree of COX-1 versus COX-2 inhibition. Remember that varying degrees of COX-1 inhibition may occur. Even COX-2 inhibitors exhibit a small amount of COX-1 inhibition at higher doses. These differences cause differences in the frequency of adverse GI effects. Potency of the different therapeutic effects must be considered. For example, one drug may be a relatively weak anti-inflammatory, but a potent analgesic that may be used for pain rather than inflammation. You need to consider pharmacokinetic components, which include duration of action, frequency of dosing, protein binding, which affects drug interactions, and renal excretion, which is affected by renal function. You need to consider the relative frequency of adverse events, especially GI, renal, hepatic, and cardiovascular. You need to consider the specific use that it's intended, and the specific indications for each drug must be known, and whether the drug is an over-the-counter product or is available by prescription only. Patient variables should be considered. These include medical condition, especially renal and hepatic function, as well as cardiovascular status, age, ability to comply with dosing schedules, and reliability of the patient in promptly reporting any adverse effects. In addition, costs need to be considered. All of these drugs except the celecoxib are available as generics. A common practice is to use aspirin nonsteroidals for anti-inflammatory purposes for a specific period, whereas these agents often are used for acute pain only once or twice. Initiate treatment with the starting dose. The analgesic effect should be noticed within 1 to 4 hours of administration. However, the full anti-inflammatory effect will not be apparent until after a few weeks. You should increase the dose until therapeutic effects are seen or the patient experiences adverse effects. Patient's response to one of the nonsteroidals does not predict whether what the response will be to any other nonsteroidal, even one within the same drug class. If pain cannot be managed adequately with nonsteroidals, you need to consider other options. If the patient experiences GI distress or is at a high risk for GI bleeds, co-administration of H2 blockers, protein pump inhibitors, or misoprostol may be considered. H2 blockers and protein pump inhibitors may provide some benefit, but only misoprostol is acceptable for preventing both gastric and duodenal ulcers. It may be started at the approved dose of 20 micrograms 4 times a day with food, and if the patient experiences severe diarrhea, the dose can be decreased to 100 micrograms 4 times a day or 200 micrograms twice a day with food. Aspirin products have largely been replaced by nonsteroidals. A trend toward an increasing use of COX-2 inhibitors has also occurred because they offer a reduced risk of GI distress. This has allowed the use of nonsteroidal treatment for many patients who were formerly unable to use these agents. However, all nonsteroidals still have adverse renal, hepatic, and cardiovascular effects. The cost of Coxib, the only nonsteroidal available in generic form, is also a major limitation. Insurance companies often limit reimbursement or require pre-authorization unless the patient has had an adverse reaction to non-selective nonsteroidal anti-inflammatories. For the treatment of osteoarthritis, non-pharmacological treatment includes proper exercise with rest periods. A supervised walking program can improve functional status and recommend weight loss to overweight patients to reduce strain on the joints. The patient must be realistic about the limitations of the medications and about his or her own prognosis. For the pharmacological treatment of osteoarthritis, acetaminophen may be effective in treating the pain of osteoarthritis, but many patients have minimal inflammation. Patients with mild osteoarthritis should be started on acetaminophen. If this is not effective, nonsteroidals can be used. Nonsteroidals are more effective than acetaminophen for osteoarthritis of the knee or hip. They are also more effective in moderate to severe disease. Some patients' conditions can be managed long-term with acetaminophen therapy with short-term use of nonsteroidals for flare-ups. Because of the decreased risk of GI toxicity, COX-2 inhibitors are useful for long-term management of osteoarthritis, especially in the elderly patients. Intra-articular injections of steroids can be provided to these patients on a limited basis. Topical creams such as capsaicin can also help with the pain. Surgical measures such as a hip or knee replacement may be necessary if the joints are seriously affected. Pharmacological treatment of nonsteroidal of rheumatoid arthritis is often used with nonsteroidals are often used for this. Non-pharmacological treatment for acute and mild and moderate pain from rheumatoid arthritis includes rest, ice, compression, and elevation for the first 24 hours. And then these actions are the cornerstone of therapy, and then you can move on to non-pharmacological treatment. For pharmacological treatment for acute mild to moderate pain, for minor problems, start with the patient on nonsteroidals immediately. In large muscle injury with the possibility of continued bleeding into the tissue, you need to wait 24 hours to prescribe. This is because the nonsteroidal affect platelets. Usually short-acting products such as ibuprofen are used. These are given for a limited time, usually 1 to 2 weeks. In addition, nonsteroidals are used for a large variety of minor musculoskeletal problems such as low back pain, bursitis, tendinitis. They're also used frequently for chronic pain. Pharmacological treatment for dysmenorrhea includes nonsteroidals. It should be started 24 to 72 hours before the patient starts menstrual bleeding. The medication should be taken on a routine basis for 2 to 3 days. It's important that the nonsteroidals are not used during pregnancy. For the pharmacological treatment for reduction of cardiovascular risk, Aspirin at the dosage of 325 milligrams may be taken every other day or 81 milligrams daily to reduce the incidence of MI or stroke. An 81 milligram enteric-coated aspirin is commonly used because of the decreased risk of GI toxicity. The use of aspirin with some nonsteroidals, including ibuprofen, has been shown to reduce cardioprotective effects of aspirin. However, naproxen does not appear to have this effect. How do we monitor these patients? For all the drugs, you need to monitor for adverse reactions, especially GI distress, renal and hepatic function, and subjective report of relief of pain. For the aspirin products, you need to monitor for vertigo, tinnitus, and impaired hearing, and serum concentrations can be measured. For nonsteroidal anti-inflammatories, the short-term use of acute minor pain should be relieved within 1 hour. Long-term use, you need to get a baseline CBC and differential, creatinine, urinalysis, potassium, and liver function tests. Check when the product is started, and then every 3 months until the patient is stable, and then every 3 to 6 months. You need to follow patients weekly after initial beginning of the therapy to determine pain relief and or early side effects. Relief of pain, such as rheumatoid arthritis, may take up to 2 weeks, and the patient needs to know this. GI bleeding can occur any time during therapy, so you need to assess for bleeding tendencies by monitoring the CBC, PT, urinalysis, and stool for occult blood. For patients' variables, geriatric patients or elderly patients are more susceptible to adverse effects, especially slow GI bleeds leading to anemia. This can be manifested as fatigue or lethargy, GI, CNS, and renal effects. Nonsteroidals can cause confusion, particularly in the elderly patient. Renal clearance may be decreased. Rarely observed increases in serum potassium can occur in the elderly, those with renal disease, and those on potassium-sparing diuretics. You need to use the use with antihypertensive agents requires monitoring for increasing hypertension, edema, or other signs of congestive heart failure. These have been found effective to treat men with low-dose aspirin to cut the absolute risk of cardiovascular disease, most notably the risk of first heart attacks and stroke. Patients at risk for cardiovascular events should be given a regular low-dose aspirin, depending on the cardiologist's recommendation. However, aspirin resistance may raise the risk of severe stroke. The prescription of aspirin has been found to be ineffective or even harmful in primary prevention of heart attacks or strokes in women. The regular use of aspirin in elderly patients seems to worsen some forms of age-related macular degeneration, although there's no definitive link between aspirin and vision loss. Other research suggests aspirin may be tied to lower risks of liver cancer. Among hypertensive patients with cardiovascular disease, chronic self-reported use of non-aspirin, non-steroidal anti-inflammatories was associated with an increased risk of adverse events during long-term follow-up, including kidney cancer. Non-steroidal use has been associated with a reduced risk of several other types of cancer, including colorectal, breast, and prostate. For pediatric patients, a possible association has been noted between the development of Reye syndrome and the use of aspirin as an antipyretic in children and teenagers who have varicella or an influenza virus infection. Dehydrated children also have an increased risk of susceptibility to toxicity. The use of nonsteroidals in the pediatric population is not as common, except in children with a diagnosis of juvenile arthritis. Ibuprofen, naproxen, and indomethacin are available in liquid form. Naproxen may be useful because it does not have to be given as often as the ibuprofen and is safer than indomethacin. The elixir or suspension dosage should be watched carefully because the drug concentrations may vary. It's very easy to give small children an overdose if the correct product and dosage is not given, and parents need to be warned of this. In general, ibuprofen should not be used more than 3 days for the treatment of pain in pediatric patients. For those women who are pregnant and lactating, the use of these medications is not recommended in women who are pregnant. Non-steroidals must be discontinued prior to the expected due date due to prevent excessive bleeding. Babies whose mothers have taken aspirin or naproxen during pregnancy have a small but increased risk of developing some rare birth defects. Research does not support the co-administration of aspirin products and does not support that co-administration of aspirin produces better IVF results. Many of these medications are considered category C. This includes ibuprofen, naproxen, and celecoxib. Category D includes aspirin. It may be teratogenic or produce hemorrhage. The women should avoid use during pregnancy, especially during the third trimester. And considered category D in the third trimester of nonsteroidal anti-inflammatories or near the time of delivery. Aspirin and nonsteroidals such as naproxen, ibuprofen, COX-2 inhibitors are excreted in the breast milk. For patient education, all these drugs can cause serious GI bleeding. The patient should report any signs of GI irritation, pain, emesis, diarrhea, or the presence of blood. They should stop taking the drug immediately and call their provider. The patient should take these medications with meals or with food or milk to avoid GI distress. A full glass of water is also recommended. The patient may take these drugs with antacids, but they should refrain from drinking any alcohol. The patient should take medication around the clock every 6 hours, not just 4 times a day, to maintain the best serum concentration. Finally, the patient should not take more than one drug from these two classes of drugs concurrently. Nonsteroidals are present in many of the over-the-counter cough and cold preparations, so patients often take multiple nonsteroidals unknowingly. For the aspirin, the patient should discard aspirin if tablets exclude a strong vinegar-like odor. If necessary, they should stop taking aspirin 5 to 10 days before any surgery. This depends on the procedure and the surgeon's preference, and this is to avoid any problems with platelets. For the non-steroidal anti-inflammatories, the patient should notify their healthcare provider if they become aware of shortness of breath, wheezing, dizziness, GI distress, pruritus, or skin rashes. If necessary, they should, their healthcare provider, they should stop taking nonsteroidals 3 days prior to surgery. This again depends on the procedure and the surgeon's preference to again avoid any problems with platelets. For aspirin, contraindications include suspected hypersensitivity to aspirins or nonsteroidals because anaphylaxis is not uncommon. Hypersensitivity may be exhibited by acute bronchospasms, generalized urticaria, and angioedema, severe rhinitis, and shock within 3 hours of ingestion. Foods that contain aspirin may contribute to the reaction. These include curry powder, paprika, licorice, Dictine liquor, prunes, raisins, teas. Cross-sensitivity may occur between aspirin and other nonsteroidals that inhibit prostaglandin synthesis, and between aspirin and teratizine. Patients should avoid this in the 3rd trimester of pregnancy. Those who are hemophilia, who have had bleeding ulcers and hemorrhagic states. The use of aspirin in children less than 16 years of age with influenza or chickenpox may be associated with Reye syndrome. Reye syndrome presents with vomiting, lethargy, and progresses to delirium and coma. It's rare, but mortality rate is 20 to 30%. They should be used with caution with asthma, rhinitis, nasal polyps. Aspirin hypersensitivity is more prevalent with these diseases. Finally, tinnitus, dizziness, or impaired hearing probably represents blood aspirin levels that can be helpful in dosage titration. Temporary hearing loss disappears gradually when the drug is discontinued. For warnings, precautions should be used with chronic renal insufficiency. Aspirin can impair renal function, hepatic function impairment, hypothromboemia, and vitamin K deficiencies. Aspirin can cause hepatotoxicity and bleeding. Gastric ulcers, peptic ulcers, mild diabetes, gout, erosive gastritis, or bleeding tendencies may occur because of GI irritation and bleeding. Severe anemia, history of coagulation defects, or use of anticoagulants should be cautioned because aspirin interferes with hemostasis. Aspirins are included with many other combination medication products. Patients taking long-term therapy should be careful not to overdose with other non-prescription analgesics. Controlled release aspirin has a long onset of action and is not recommended for fever or short-term pain control for children younger than 12 years of age. It is also contraindicated in children with fever and dehydration. For the pharmacokinetics, rapid and complete absorption of aspirin occurs after oral administration. The bioavailability of aspirin depends on the dosage, formulation, particle size, presence of food, gastric emptying time, gastric pH, and antacids or buffering agents in the stomach. Food slows the absorption of succinylate. The bioavailability of enteric-coated products may be erratic. Absorption from rectal suppositories is slow with lower succinylate levels. They are particularly hydrolyzed to salicylic cyclic acid during absorption, and this is distributed to all body tissues and fluids, including the CNS. Adverse effects we've gone over, as well as drug interactions. You need to look this up when you're prescribing. For overdosage, it's life-threatening with aspirin and requires intensive support treatment in hospitalized settings. Initial symptoms include respiratory alkalosis with hyperpnea and tachypnea, nausea, vomiting, hypokalemia, tinnitus, headache, dizziness, confusion, dehydration, hyperthermia, hyperactivity, and hemolytic logic abnormalities. This will progress to a coma and respiratory collapse. For dosage administration, you need to look these up prior to prescribing. Dosage based on the condition and weight, especially in the younger population. For nonsteroidals, one of the most common is ibuprofen, which is Motrin, etc. Contraindications include hypersensitivity. Nonsteroidals have potential cross-sensitivity to other nonsteroidals or succinylate. If the patient has asthma, rhinitis, urticaria, nasal polyps, angioedema, bronchospasm, or other symptoms of allergic or anaphylactoid reactions, he or she should never receive another nonsteroidal. Ketorolac or Toradol is contraindicated in patients with previously documented peptic ulcer and GI bleeding. Indomethacin should not be given to patients with active GI lesions or a history of recurrent GI lesions unless the high risk is warranted and patients can be monitored very closely. For pregnancy, these should not be given in the 3rd trimester. Congenital heart disease in which patency of the PDA is necessary for pulmonary or systemic blood flow. Bleeding, especially with active intracranial hemorrhage or GI bleed. Thrombocytopenia or coagulation defects. Proven or suspected necrotizing enterocolitis. Significant renal dysfunction and perioperative pain management. Post-coronary artery bypass graft surgery. These are all contraindicated for the use of aspirin. Use of nonsteroidal anti-inflammatories. For warnings, these medications do have a black box warning. For cardiovascular, it may increase the risk of serious and potential fatal cardiovascular thrombotic events, MIs, and stroke. Risk may increase with the duration of use. Possible increased risk of cardiovascular disease or cardiovascular disease risk factors. For GI, again, increased risk of serious GI adverse events, including bleeding, ulceration, and stomach or intestinal perforation, which can be fatal, may occur at any time during use and without warning symptoms. Elderly patients are at greatest risk for the serious GI events. For GI effects, many minor upper GI problems such as dyspepsia are common. These usually develop in early therapy. For the CNS effects, depression, drowsiness, headache, and dizziness, especially in the elderly. Renal function impairment, nonsteroidal metabolites are eliminated primarily by kidneys. They need to be used with caution in those with renal function impairment, and reduced dosages is recommended. Finally, hepatic function impairment may occur. For precautions, you need to be cautious in a patient with prior history of GI disease. The risk for bleeding increases with age. The risk of GI bleeding for a person between the ages of 25 to 49 is almost zero. However, this risk increases steeply from 60 to 69 years, from 70 to 80 years of age, and the risk almost doubles. Corticosteroids, non-steroidals are not substitutes for these drugs. You should not discontinue corticosteroids abruptly when starting a patient on nonsteroidals. The corticosteroids should not be given concurrently with nonsteroidals. Nonsteroidal anti-inflammatory drugs' reversibility inhibit platelet aggregation. You need to be aware of this. Cardiovascular effects may cause fluid retention and peripheral edema. Use caution in cases of compromised cardiac function or hypertension, in patients with long-term diuretic therapy, and in use with other conditions that predispose fluid retention. Agents may be associated with significant deterioration of circulatory hemodynamics in severe heart failure and hyponatremia, presumably because of the inhibition of prostaglandins-dependent compensatory mechanisms. They do have ophthalmic effects. Perform ophthalmic studies in patients who develop eye complaints during therapy. Effects include blurred or diminished vision, changes in color vision, corneal deposits, and retinal disturbances. Discontinue therapy if ocular changes are noted. You need to be cautious with infections. Nonsteroidals may mask the signs of infections. Again, the renal effects: acute renal insufficiency, interstitial nephritis and hematuria, nephrotic syndrome, proteinuria, hyperkalemia, hyponatremia, renal papillary necrosis, and other renal medullary changes may occur when taking nonsteroidals. You need to administer these medications with caution due to dehydrated patients, and hyperkalemia is a potentially serious non-steroidal anti-inflammatory induced renal electrolyte abnormality. For the hepatic effects, borderline LFT elevations may occur in about 15% of the patients and may progress, remain essentially unchanged, or become transient with continued therapy. The alanine aminotransferase test is probably the most sensitive indicator of liver dysfunction. Alcoholics are at risk for adverse effects because of the toxic effects of alcohol on the gastric mucosa and liver. Patients commonly underreport their drinking, so all patients should be warned about the risks of bleeding and liver toxicity associated with use of alcohol and non-steroidals at the same time. And photosensitivity may occur in patients taking non-steroidals. For the pharmacokinetics, analgesic effects onset generally occurs in 30 to 60 minutes and lasts for 4 to 6 hours. Anti-inflammatory response onset may take up to 1 to 3 weeks. Indomethacin has a faster onset of anti-inflammatory effects than do other non-steroidals. For adverse effects, the most adverse effects have been discussed. These drugs have a large number of possible side effects. And the frequency of the various adverse reactions varies by drugs. Dosage and administration, again, you need to look this up when you're prescribing to a particular patient. And a lot of these are based on age, weight, and use.